Hello, good afternoon. Dr. Trudy Ufundu of Snowspirations Global Health Solutions. Thank you and welcome to our YouTube Open Clinic on weekends. Today we're going to look at uterine adhesions. Remember, anywhere you see the uterine, you replace it with womb. So we're looking at womb adhesions and how you can maximize your possibility and your chances of pregnancy. So when we talk about uterine, we are referring to the womb. So womb adhesions. How can we overcome the adhesions, which are scar tissues located inside the womb, so you can ultimately achieve pregnancy, carry pregnancy to term, and ultimately become a mother? This will be the topic of discussion this afternoon. The first few minutes, I'm going to give my presentation. Then afterwards, you have an opportunity to ask your questions. My name is Dr. Chidi Ufundu. I'm the convener of this group. If today is the first day attending the clinic, thank you so much. And please sit back so we can gain one or few information so we can know better what to do if we happen to have this challenge. It's important to understand that uterine adhesions is a temporal thing. If you follow the process, if you have a very good provider, you can still overcome the difficulties and you can still become pregnant. Okay? Now, the uterus, it's covered with what we call uterine cells, endometrial cells that nourishes the womb. They are called the endometrial lining. This endometrial lining will provide nourishment and sustenance when eventually you become pregnant. So the natural process of pregnancy, the egg will meet the sperm in the tube. They will, go through the process of fertilization, leading to embryo. Then they will come down to implant in the womb. Now, if you have scar tissues, which is also called uterine adhesions, the process of implantation will not happen. Because for implantation to happen, you have to have adequate thickness of the endometrium. So when you have scar tissues, the ability of pregnancy to implant will be affected. Now remember that the endometrial cells will provide nourishment and sustenance for the baby for the 42 weeks in your belly. So if that happens, it will affect your ability to become pregnant. Now, thankfully, once we are able to diagnose uterine adhesions on time, you might have a possibility of overcoming it and becoming pregnant. Now, anything that leads to adhesions, which can be infections, which can be a pathologic gynecological condition. So if you have infections, infections can be pelvic inflammatory infection, which can come from untreated sexually transmitted infection, chlamydia, and gonorrhea. If they are poorly treated or if they are not treated at all, they can lead to formation of adhesions. If you have endometriosis, in endometriosis, for some reasons, the cells that ordinarily should be limited in your womb is seen elsewhere. So women that have endometriosis can also have adhesions, which can affect the womb. If you have prior surgeries on the womb, so myomectomy, cesarean section, polypectomy, any procedure that has been conducted inside the womb can lead to adhesions when healing process is going on. Normally, when any wound in the body is healing, it will heal with what we call first intention. When any wound in the body heals with first intention, we won't have any scar tissues. But unfortunately, the cover of your womb is very sensitive that sometimes, even when we are done with myomectomy, which is the removal of the fibroid, or we go for CS, which is the removal of your baby, or we go for polypectomy, which is the removal of the polyps, in course of healing, the cover will heal by secondary intention. So when a wound is healing by secondary intention, it means it will heal with scar tissues. And when the cover of your womb has scar tissues, pregnancy will be affected. Now, any of the procedures I mentioned can lead to scar tissues. It can happen to anybody. Sometimes we don't even know why it will happen. So some women that won't have surgeries, some women that didn't have infections, some women that didn't have endometriosis can end up developing uterine adhesions. Now, what's the problem when you have this? You see this cover, you see the surface, very smooth, Very good, very encouraging. When you have scar tissues, the two opposing sides of your womb will kind of come together. And when it comes together, then the possible role of the endometrium will be affected. When this happens, then you will not have opportunity of becoming pregnant. Unfortunately, if you have adhesions and you don't go to a specialist, in course of correcting adhesions, you can cause more problems. This is the same thing that happens to the tube. So the tubes are very sensitive. The cover of your womb is very sensitive. So in course of trying to correct adhesions, if it's not done by a gynecological surgeon, they will cause further damages. So it's something that needs expert approach. Now, can you become pregnant when you have this? Yes. What do we need? Expert approach. Now, what are the symptoms? What are the likely things that will indicate that you might likely have adhesions? Unfortunately, some women will be asymptomatic. Asymptomatic means you don't have any symptoms. You probably started having problems with becoming pregnant. Then suddenly we discover that. Now be careful. Your past medical history is important. There are some women that have had termination of pregnancy illegally through D&C, dilatation and curettage. Now, in course of doing that dilatation and curettage, sometimes they can go deeper. In course of scraping it, dilatation means you dilate, then you curettage, you remove. So in course of removing an ongoing pregnancy, they can cause problems there. You can also have this when you go for evacuation. Remember, anytime your pregnancy is not viable, we want to evacuate, we want to clean the womb so that you have another opportunity to become pregnant. So some women will not have any symptoms. Some women will have abnormal cycle, abnormal bleeding, heavy bleeding. Some women will present with pelvic pain, excruciating pelvic pain. Some women will also present with gastrointestinal problems like bloating, constipation. But ultimately, the biggest signal you might have endometrial issues in regards to your adhesions is what? Infertility. So if every other factor is checked in the woman, is checked in the man, but after a period of 12 months, you are still not able to achieve pregnancy, then it's likely we have to begin to look inwardly to see if we can decipher what the problem is. So the ultimate presentation of uterine adhesions is what? Infertility, inability to become pregnant, which can be primary infertility or become secondary infertility. Now, how can we get help? How can we achieve pregnancy if we have uterine adhesions? Seeking professional help. Seeking professional help under a gynecologic surgeon. It's something that can be done. What are we gonna do? We will carefully identify all those adhesions, which will also cause scar tissues, and we carefully, through a laparoscopic means, remove it and give your womb time to heal. So adhesiolysis, it's what it's called. We carefully remove the adhesions. We carefully remove the scar tissues. Then we create an opening so that the surgery site will heal properly. Most times after doing this, we can place you on IUD, we can place you on a balloon to make sure we create enough room so that the cover will heal properly. Sometimes we'll also support the cover of your womb with a couple of combination of hormonal treatment of estrogen and progesterone so that we can get a likely good healing that will give us good lining. Because for you to become pregnant, for you to carry your pregnancy to term, we have to have adequate quantity of progesterone, adequate quantity of estrogen. So if anything happens to this estrogen progesterone balance based on our hormonal assay, then we can follow through and make sure we give you some hormonal treatment so you have adequate thickness that will support pregnancy. So if you have identified uterine adhesions, you can overcome it by going through what? A specialist who will conduct a carefully, minimally invasive laparoscopic adhesiolysis. Forget the big medical jargon. The simple thing means we need to go in, we need to carefully identify only the scar tissues and remove it. I'm emphasizing on this because not all doctors will carry out this. The doctors that will carry out this will be board certified gynecologic surgeon. They will take time. They will diagnose. They will go in with careful precision, find out where all those adhesions are, completely remove it, allow recovery. Once recovery is confirmed, then you can begin to try for pregnancy. Now, listen to me carefully. It's important you get this right, especially if you're 35 years and above. Because when you get to that age of 35 years and above, your ability to succeed in becoming pregnant by yourself, it's reduced based on natural process of reduction in the egg and the quality and the quantity of the eggs you have. So if you currently have adhesions, it was diagnosed, there's a particular one we call Asherman syndrome or uterine synechia, you need surgical correction. So how do we know? You go through a trained gynecologic surgeon. We identify it, we allow you to heal properly, then we go back and we begin to see what we can do to help you to become pregnant. This is my quick presentation on this. Now, I'm going to allow you to ask your questions so I can provide you feedback. So the floor is open. Please ask your questions. Remember, we have a special community in YouTube. So if you need exclusive conversation, exclusive outreach correspondence with me, click on that join community link. Then you can decide the one that will give you one-on-one access to me. Okay? So please, the floor is open. Feel free to ask your questions and I'll provide you feedbacks in real time. So the questions are open to come in now. Please ask your questions. Ask your questions, please. Do you have any questions? Good afternoon, Tosi or Paradiran. Thank you for coming. I hope you've registered for the event in May. If you are in our group, we have a big event in May. We have a special super masterclass for advanced and maternal age members. If you are 35 years and above and you're still currently struggling to become a mother, you have an opportunity to fellowship with us on the 29th of this month. We're going to have a solid panel that will walk the walk with you, encourage you, identify the problems, proffer solutions, refer you if need be. Every singular member in our community, if you're having these problems and you need help, please register. Can retain placenta cause infertility? Yes. Anytime you have unsuccessful pregnancy, we want to remove every singular thing that came with that pregnancy completely outside your womb. Now, the very last step in the process of pregnancy is delivery of the placenta. So pregnancy has not ended if we have not delivered the placenta. All parts of the placenta must be completely removed. Unfortunately, in some women, they can have retained or adherent placenta to the womb. What do we need? We need to go in, we need to carefully remove it. So retained placenta can affect your ability to become pregnant because once pregnancy is ended, we need to bring the womb back to the ground zero. So placenta parts must be completely removed. If unfortunately you had miscarriage or you had stillbirth, remember the difference between miscarriage and stillbirth? 20 weeks. So 20 weeks is the cutoff point. If unintended loss of your pregnancy happened before 20 weeks, it's called miscarriage or abortion. Remember, in medical field, miscarriage and abortion, it's the same thing, right? Hopefully, we can attend to all the questions, okay? How does uterine scar tissues affect pregnancy? Remember, if you have uterine scar tissues, you will struggle to become pregnant. So it's important we correct it on time. Now, in some women, if they succeed in becoming pregnant with the same uterine adhesions, then we probably need to support that pregnancy because the most important thing that will help you to have safe pregnancy is sustained progesterone. Progesterone is the pregnancy maintaining hormone. So if you succeeded in becoming pregnant, despite the uterine adhesions, then we need to keep a close eye on that lining, which the two components of hormones that will sustain your lining is estrogen and progesterone. So you need to be under close monitor, okay? That's what you need. So you need to be very careful. All right? Can one have successful IVF with uterine adhesions? We don't encourage any pathology inside the womb if you are going for a psychologically, financially, emotionally challenging process as IVF. So a good IVF provider will make sure that the state of your womb is completely taken care of. One of the things we do in IVF is to give you some drugs that will prime the cover of your endometrium. So if we don't have a particular thickness when we are going for IVF, we are not going to proceed. So a good IVF provider definitely will take a look, and if we notice there is an adhesion, then we correct it first. IVF is a very expensive process, very delicate, very, very sensitive. So if we're going to go through that route, we must get it right. We want the womb to be as empty, as healthy as possible. So if we identify adhesions in course of preparing for IVF, we have to remove it surgically. Must remove it surgically. Okay? Can uterine adhesions cause miscarriage? Not directly, but indirectly it can. Anything that affects the integrity of the endometrial cells can lead to miscarriage. So the answer is yes. So you can actually be pregnant. Your urine and blood pregnancy test will show that you're positive for pregnancy, but because that environment is not user-friendly, you can lose the pregnancy. So the answer is yes. So it can happen. Okay? All right. Thank you, Doc. If laparoscopic surgery is not an option, what's the way forward for a believing for baby woman? Then we go the normal other route. So laparoscopic surgery is the newer trend, right? Based on keyhole, and we go in there and we do what we need to do. If that particular facility, if that particular technology is not available, then we do what we normally do. We can go in, to the vaginal route, or we can do laparotomy. Okay? So if laparoscopy is not available, we go the natural way. But by any means, we need to remove the adhesions. Any means possible, we need to go in there and remove the adhesions. If we don't remove it, your chances of becoming pregnant will be affected. Okay? All right. For sustaining pregnancy with progesterone, how long into the pregnancy should the progesterone be taken? This is exactly the decision of your provider, depending on your need, depending on your level. So there is no one size fits all. The duration of your progesterone, the route of your progesterone, the strength of your progesterone prescription is based on your own individual need. So it's dependent on the quantity of progesterone you have. So it's tailor-made. There is no one size fits all in hormone treatment. Okay? All right. One of my colleagues, Oge, is tuning in from UK. Oge, thank you for coming. Remember to join Oge in Health and Music with Dr. Oge. She's in UK, amazing lady, and mentoring medical students, doing amazing things. Oge, thank you for coming. Oge, if you wouldn't mind, you can ask your questions too. What are the symptoms associated with Asherman syndrome? So Asherman syndrome is actually a type of uterine adhesions. Most times when you have Asherman syndrome, you probably went for D&C. Previously you went for evacuation, you had PID. So Asherman syndrome is also a presentation of uterine synechia or adhesions. So in Asherman syndrome, most women will start having irregular period. Most women will not even bleed again because the cover of your womb is kind of gummed together. So the outlet will be affected. Some women won't have any symptoms. Okay? But if you go for clinical diagnosis and we're able to pick Asherman syndrome, you're also a candidate that should go for adhesiolysis. Asherman syndrome is just a type of uterine adhesions or uterine synechia. Okay? Guys, ask your questions so we can round up. If we can round up in 20 minutes, that would be nice. If you have questions, please feel free to ask. Okay, please go ahead and ask your questions if you have one. Okay? Okay. Thank you, Doc. This came at the right time. You'll be going for your hysteroscope after your period. Please, can they remove the fibroid? Fibroid surgery is not a passive thing. You can't go for hysteroscope and they are removing fibroid. It doesn't make sense. If you are going for myomectomy, if it's laparoscopic source, if it's laparotomy, then they will tell you exactly. We have to learn how to separate all these procedures. I know there are some women that in course of, CS, they will remove the fibroid at the same time. It's never advised. You have to treat them as two different entities because The problem in going into the woman's womb is bleeding. Sometimes you go in there and you can't control the bleeding. So if we are going for CS, we are removing the baby. If you're not going for CS, we are going for myomectomy. And unfortunately, once you become pregnant, nobody can gain access to your womb until you deliver your baby. So my sister, you're going for hysteroscope. When you're going for hysteroscope, we just want to have a look into your womb to see what's going on there. Now, depending on the size of whatever we can see there, they can do one of few things. But that's not the best time to go for myomectomy. You have to have a definitive procedure that will take care of the fibroid. So your myomectomy should be a separate procedure from your hysteroscope. Okay? All right. Oge has a question. How long after fibroid surgery can couples commence IVF? So it's dependent on the recovery. You know, when we go for fibroid surgery, which is the commonest surgery you can have out there in gynecology, if everything goes okay and a couple, weeks, some clients can recover as soon as 2 months. Once you're fully recovered, you're not going to be the person that will know if you're fully recovered. You're going to go for your post myomectomy appointment. We'll check. We make sure everything is good. Then we make sure your cycle, your period has returned back. Most times we want to have 2 regular cycles. So sometimes you're looking about 3 months, but everything is all tailored based on your age, based on your fertility issues. Some women can do so well, and within 1 month, we can go in and start the process of IVF. But everything is tailored to the individual lady's need. But please, when you have gone through myomectomy, don't go trying to become pregnant by yourself. Matter of fact, some providers will place you on contraceptives to make sure you won't become pregnant within the time you're healing. Anytime we have any procedure done in the body, we want it to be healed. Now remember, your myomectomy is the same thing with CS. The only difference is the fact that when we go for myomectomy, we are removing the fibroid. When we go for CS, we are removing the baby. So one is good, one is the abnormal thing. So when you are going for this, anytime you have surgery, you have to recover. And what's the gold standard? 18 months. 18 months to recover before starting to plan for another baby. Allow 18 months. The reason is because the more you give time for your womb to recover and be completely healed, the more the integrity of the womb will be sustained. The problem is when you don't give space for your womb to recover and you quickly become pregnant, the integrity, some women can have what we call womb dehiscence. You can have breakdown of that womb, which subsequently can predispose you to having uterine rupture, which is a nasty emergency you don't want to witness. Beautiful question from Oge. How does this affect the chances of success? You see, like I mentioned, IVF is a very careful process. So a very good IVF provider, you can go for your ultrasound and you discover you have 2 types of fibroids, submucosal or intramural fibroid, and they are bigger than 6 cm. The natural ideal thing to do is to remove them. Remember, some women will come in and say, oh, doc, I have fibroids and they told me not to take folic acid. No. Every singular woman that wants to become a mother should take their folic acid. The gains from folic acid far outweigh any hypothesis out there. So if you have significantly big fibroid, prior to your surgery, prior to your IVF, remove them. Don't proceed. And of course, a good provider will not do that. There is no good provider that will proceed with IVF with 6 cm fibroid, 6 cm submucosal fibroid or intramural fibroid. That's not a good provider. We want your womb to be as clean, as empty as possible if you're going for IVF. IVF is very expensive. IVF is challenging. IVF is emotionally draining. So they give you a lot of injections through a long time. Then you pay a lot of millions. And because of something we could have done correctly, we're not doing it. It's a careful process. So a good provider will take time. Anytime, even in cost of building your womb, the lining, if we don't have adequate thickness, you're going to cancel the procedure. I'm sure some of you started preparing for IVF and they said, hey, madam, we're not going to continue because we didn't get where we want to be. But a bad provider, which unfortunately there are some people out there that are just interested in your money, they will know that this is not going to succeed. They will still go ahead and continue, knowing fully well it's going to fail. But we don't do that. A good provider will tell you the truth. Sometimes you won't like the truth. Sometimes it will be very uncomfortable. But truth is truth. If you are going for IVF and we are not satisfied with the cover of your womb, and we are not satisfied with the development of the follicles, and we are not generally satisfied, we have to cancel it. Some women can have complications in course of preparing for IVF. They can have what we call ovarian hyperstimulation syndrome. So your body is reacting, the ovaries are getting enlarged, we cancel it. It's better we take time. If it's going to take us 6 months to get a successful IVF, we'll do that. We are not in a hurry. The overall aim of IVF is not to take your millions. The overall aim of IVF is to have success. So if we are building you up for IVF and we don't have good response, we cancel it. Very important. So I'm just empowering you now. If you're going for IVF, make sure you get our guide. There are specific questions you ask your IVF provider. And of course, you demand your report. Anytime you're seeing any doctor, demand your report, demand your medical reports, demand your progress report. If you're going for IVF, we want a comprehensive report of how the IVF fed. If you're going for IVF, we want to know the grade of the sperm, we want to know the grade of the egg, we want to know the grade of embryo, because those are the things that will determine if you're going to have good outcome. Don't just go because other people are going. Go and ask the simple, important question about your health. This is your right. When you part with your money, when you're entrusting a provider with your health, it's your right to demand a report, though politely. This is why you need to go with your male partner so that he can ask questions. And there are some providers that will see only women and they will begin to think maybe she's not even serious. But when you go with your male partner, when your male partner is asking meaningful questions, look, I'm telling you globally, when you see a doctor and you're going as a couple and you're well-learned and you're respectful, they will up their game. Look, I know why I'm telling you this. Never allow your woman go for any fertility appointment alone, including the ANC. Be the person that will take her to that clinic. Be there, ask questions, be knowledgeable. Be the person that will be the leader. Stop pleading only when the product is out. Stop pleading only when the babies are born. You begin to throw party up and down. Go for all appointments. Book all appointments. Go there, ask questions, support her. And when they are taking a couple of all these hormonal drugs, sometimes it's going to affect their mood. Sometimes they won't be in a good place. Sometimes they will be moody. Sometimes, things will happen. You are there supporting her, knowing fully well that this is a phase. So very important. Secondary infertility, it's a very big, broad spectrum aspect. Secondary infertility can come from the man. Secondary infertility can come from the woman. In secondary infertility, you were pregnant in the past. You had your baby. You aborted. You had medical abortion. But currently, you're not able to become pregnant. So secondary infertility means in the past, you were able to become pregnant and you decided to keep the baby, or you aborted the baby, or you had miscarriage, or you had stillbirth. But currently, you are struggling to become pregnant. That's secondary infertility. The opposite is primary infertility. In primary infertility, you have never been pregnant in your life. Then for the man, in primary infertility, you have never impregnated any woman, and currently you're still not able to impregnate your woman. But if you have secondary infertility, in the past, you impregnated your girlfriend, you impregnated your wife or whoever, and currently you're having challenges. Now, secondary infertility can come from the man. It can come from the woman. It can be the tubes. It can be the hormones. It can be your body weight. It can be infections. It can be structural problems. It can be the sperm. So it's a whole lot that can happen. Okay? All right. Okay, my wife is asking a question. What will prompt an investigation into the presence of uterine adhesions? Ultimately, infertility. Infertility is the ultimate presentation of uterine adhesions, right? Now, like I mentioned, some women won't have any presentation. Some women will have uterine pelvic pain, excruciating pelvic pain. Some women, suddenly your cycle will change. Suddenly your cycle will cease. Because if you have this, the cover of your womb will no longer be the same. So if you have a kind of a problem in your, gynecological pattern, this is why you need to study your body to know what's normal. So if you want to have a baby and in case of wanting to have a baby, you're not succeeding depending on your age. So if you're 35 years and below, 12 months. If you're 35 years and above, 6 months. If you're 40, immediately. If you are not able to get a positive pregnancy test, then we go and run a fertility assessment. Fertility assessment means we want to check the woman, we want to check the man. So for the woman, we check all the hormonal profile: estrogen, progesterone, FSH, LH, TSH, your thyroid hormones, your prolactin. Then that's number one. We check your tubes. But importantly, every woman going through infertility, we need to know the ovarian reserve. Your ovarian reserve is the rate limiting step. So ovarian reserve means how many eggs do we still likely have? And out of those eggs we have, what is the quality of the eggs? So this is the starting point in infertility management. If we go for ovarian reserve test and we discover that your AMH is very, very low, and we discover that your FSH is very high, then likelihood that you might be going into menopause, especially if you haven't had your period for 12 months. But if we go for your ovarian reserve test and we see some evidence of very good response, you still have good eggs, then we can begin to do things differently. Now, some women will go for ovarian reserve test and their AMH is low, their FSH is high, then they will be candidates for what? Donor eggs. So the indication that will warrant, knowing about presence of adhesion is what? Ultimately infertility. What history, presentation, symptoms would the individual have? If you are seeing this kind of question, then you definitely know it's coming from my wife. Amazing, very smart lady, and she keeps me on my academics, high level. So very amazing question, babe, you asked. So if we're talking about the adhesions, talking about history, we want to look at your surgical history. We want to look at your gynecological history. So this is where you start telling us if you've had myomectomy, CS, polypectomy, and also you tell us if you've had evacuation, if you've gone for termination of pregnancy, then you tell us about your gynecological history. Then we also want to know your cycle. What's your regular? If you used to have a regular cycle, then suddenly it's flipping all over the place, then we begin to look at things. Then we also look at the symptoms. Were you currently having no bleeding, but previously you used to have normal bleeding? So anything that changes in your body will be an indication and is individualized. Okay? All right, guys. Do you still have any questions? Please, if you have any questions, ask before I go. Remember, we have a special event in our group. Amazing event. You don't want to miss this. Advanced in maternal age super masterclass. Women from age 35 who are currently having problems achieving pregnancy. We have a special event for you on the 29th. You don't want to miss this. You have to be fully committed that in 2022, you're going to be a mother, especially if you want. There are some women that don't want to have kids. I hope you understand that. There are some women that naturally, they just want to have, pets. There are some women that just want to adopt pets. There are some women that don't want to have their own babies. They just want to adopt. So women are wired differently. But if you want to be a mother, regardless of your age, you can be a mother. So that's what we're going to talk about on the 29th. You don't want to miss this. Admin will give you the details. Registration is currently open. We have only few slots. Now, in our community, we support each other. If you have been blessed by my community and you feel like giving back, this might be an opportunity. You can select 10 people. You can select 5 people. You can say, I'm going to sponsor them. We have seen people that overcame infertility in our community simply by supporting other women. So imagine you struggling with infertility, but you forgo your own infertility and you keep helping other people. I have had my colleagues who are struggling with their own infertility, who are struggling with their own health issues, but they forgo their own health issues and they begin to concentrate in training other people despite their own problems. When you do this, God has a way of giving you Tara. So I'm challenging you. In this community, you have to know how to love. You have to know how to care. So you can sow into this community. You can bring forth the women that might not be able to afford our services by sponsoring them. You can have that opportunity. How can you join the group? Admin, probably, I don't know if YouTube can allow us to post our link, but you can check our website, snowspirations.com. Snowspirations.com. Admin, if it's possible to share our website, you can share. Then if you go to our website, you can see how you can benefit from all the groups. But this super masterclass, please don't miss it. The reason is this. Let me give you an example. You see, if you are 39 in 2022, okay, and by 39, there are so many changes in your body. If you pay attention to your body is already giving you signals. Your cycle is kind of trying to be irregular. You're having some dryness, hot flushes, mood swings, here and there. They are signal that your body is changing. Now you're 39 in 2022. If you want to be a mother from January to December in 2022, if you don't do what you should do, guess what happened in 2022? You will invariably lose 12 eggs if you're still ovulating. Because in January, you release 1 egg. In February, you release 1 egg up to December. So 12 eggs. Those 12 eggs are 12 pregnancies. So every month, a woman is structured to be pregnant. The way God made women to be pregnant every month until you enter menopause. Do you understand me? So when you are bleeding, if every standard procedure in the body happens the way we plan it, when you are bleeding, it's failure of pregnancy. Though some women might bleed, but they might not be ovulating. But in a standard woman in her reproductive phase of life, you release 1 egg. When you release that egg, it's expected that the sperm will fertilize it. Now, if that doesn't happen, the cover of your womb, which is getting ready to receive that pregnancy, will disintegrate. This is what leads to your bleeding. So any month you are bleeding is an indication that pregnancy failed to implant. So if in 2022, you want to become a mother, but you're not doing anything extraordinary, you're just praying, you're just going about, you're just wishfully thinking and hoping you're going to be. We can't passively become pregnant. But if you actively do something in January, you actively do something in February, you keep actively doing something, there is absolutely no way, my sister, that by December 2022, you're not going to get your chance. Some people might not achieve it naturally. Some people will need drugs. Some people will need IUI. Some people will need IVF. Some people will need adoption. Some people will go for surrogacy. But by any means possible, you can be a mother. I'm sharing this message especially for tomorrow, which is Mother's Day. Don't ever think it's over. This is just the beginning. The fact you're having challenges doesn't mean your challenges are not going to end. So I'm encouraging somebody today. I want you to be among the people I will celebrate in our group. I want you to mount the podium and begin to tell your story and begin to share your testimonies. I want to celebrate your baby in this group by 2023. It is not over in any age. We have seen 50-year-old woman becoming a mother. We have seen a 51-year-old lady having 4 babies. She went for double surrogacy. So no matter your challenge, we want to meet you at the right place. We want to empower you so that you can become. Okay, thank you for coming. Okay, I have another question. What causes, okay, I've already answered that. And after transabdominal sacrilege. So sacrilege means for some reasons you have cervical incompetence. That means the integrity of your cervix is not too strong. There are two functions of the cervix. When you're not pregnant, we want your cervix to be open so that the sperm can come in. When you're pregnant, we want it to be completely closed so that the baby will not escape. But when the integrity of your cervix is not strong, you can have weak cervix and the baby can escape before term. Now, in that situation, we can give you cervical sacrilege. We can go through the vaginal route or we can go transabdominally. Transabdominal is the superior one. Now, if it's properly done, it's not supposed to be an issue. It's supposed to actually help you so that when you become pregnant, your baby can succeed in getting to 37 weeks. Any baby that gets to 37 weeks, if you deliver the baby today, they examine the baby, they send you home. But any baby that is delivered before 37 weeks, when you deliver, we keep the baby in neonatal intensive care unit so we can make sure that the baby is okay before you go home. Okay? All right. Thank you for coming. My next clinic in YouTube will be on Tuesday. But join me tomorrow. I have another clinic in our Facebook group and page. So thank you for coming. Remember, if you haven't subscribed, please subscribe. Share this channel with anybody that needs to get help. We're here to help everybody. Okay? But thank you so much for coming, for giving me the opportunity. Until I see you guys tomorrow, God bless you and enjoy your weekend. Bye-bye for now. God bless.